I just wanted to start that health equity has really become the foundation of our Ontario Health Team work. The Greater Hamilton Health Network serves a very large population. We have about 700,000 individuals attributed to our OHT that actually span 3 geographical regions. That's Hamilton, Haldimand, and Niagara Northwest. One quote that's guided me is, "Do justice to our voices and showcase our experiences that usually get dismissed." I do feel strongly and come from the point of view that these stories, this evidence has been there for a very long time. It is the solutions that and the actions that we need to focus on. When the OHT was first starting, obviously there was a lot of things going on. You know, the COVID pandemic hit very soon after. Most of the first OHTs were, just getting up and running. But, the COVID pandemic also highlighted, like we can all agree, the inequities that were already in our system for a very long time. So how did our OHT use some of these inputs? Well, we started to look at community voices more in depth, listen to lived experience, take the historical reports. There has been a lot of work, especially in Hamilton and the GTA, about the data about health inequities, those that are not accessing care, those that are. There are very well done reports that we could already access to know and use as a starting point for this work. We spent the first 6 months of our OHT actually doing a health equity framework and supplementary report. We wanted to hear from specific communities and priority populations within our OHT about, how care was, what was missing, and what their recommendations as we move this new kind of OHT model forward, where was the best, launching point for us? Coupled with the fact that there is strong, SDOH data and heat maps, healthcare outcome data that some of our partners actually already have. I think one thing, and I just wanted to highlight that I've learned over the last few years working in this space, is that being very mindful that these stories of health inequities have been told over and over again. They've been told to healthcare organizations, they've been told to people in leadership, but there hasn't been a ton of action. And in Hamilton proper, we see the life expectancy between, certain wards almost 20 years still. It's been like that for over 10 years. So just wanted to kind of throw that in, that these are stories that are there. But it's a difficult starting point because they've been heard, but there hasn't been action. Today, I want to talk a little bit about 2 initiatives that the GHHN put in place when we wanted to address health inequities of the populations within our OHT catchment. These 2 initiatives recognize that people are extremely complex, that they present with multiple issues, and they take into account the whole person. We very much took the mindset that we were not going to focus on one small portion of a healthcare disease, but rather think about initiatives that looked at the whole entire person from a health and social lens. The first example is around homelessness. The concern that we were dealing with was that, especially during the pandemic, women were presenting to shelter in high numbers. There was increased rates of homeless women being turned away from these shelter and day spaces. Women accessing shelter were becoming extremely complex from a medical and social point of view. We actually saw an increased rate of pregnant homeless women. And then we already knew from that historical data that there was inequities in funding and bed counts for women who were homeless in the system. We brought together our OHT partners to think about a co-design initiative. We went out to see women who were accessing shelter and day spaces, and we brought around the providers, and I'm not talking about just, ministry funded providers. I'm talking about social providers, food banks, not-for-profits, charity organizations, to develop the intervention. And in 2021, we came up with the Women's Homeless Health Drop-In Days. These would be low barrier, free clinics that combined health and social care delivered to where women were served. So they were held at shelters or day spaces, and they provided a whole host of things, from primary care to STI testing, cancer screening, pap smears, mental health care, newcomer services, naloxone training, but then also coupling that with social activities, art, food, gift cards, menstrual products for free. No appointment was necessary. It really became this one-stop shopping clinic space. We decided to hold this since 2021 once a season, because we also knew that as the seasons changed, the women's needs and concerns changed along with them. The results have been honestly quite staggering. We've seen over 550 women in 8 days since 2021. We've had STIs identified on site. We've accessed housing and healthcare at that point in time, delivered wound care. An amazing story from one of the days was that a woman who accessed the event got point-in-care hepatitis C testing, was positive, did not know that, but went to the next booth to actually start her treatment. Everything was there. It was trauma-informed. It was, coupled with peer support. And there's been a couple of things that have really branched off since doing these clinic days. We discovered that reproductive access was not even known within our GHHN catchment area. So we just developed the first ever abortion care pathway, which has now become the most accessed pathway on our primary care site. We've started to collect race-based and socio-demographic data at all of our clinic days, and this has actually helped inform the next days to come. But overall, it's honestly built trust between our OHT partners, the people accessing the event, and even periphery, people wanting to be part of something that feels really low barrier with a harm reduction lens. Next steps, we've just actually last week expanded these clinic days to men. We partnered with a church and a local drop-in center called The Hub. We saw 142 men in 8 hours in the shelter and church parking lot using the same kind of idea. And we still continue Women's Health Days every single season. The second example I want to talk about is housing. So the concern that we were up against was that low-income housing units within the core of Hamilton were actually being decanted and deemed not livable during the pandemic. But during this, decanting and realizing that, there are a lot of vulnerable individuals living in low-income housing in Hamilton, often the first home of homelessness, it revealed countless other issues in the vulnerable housing sector. So again, much like Women's Homeless Days, we brought together some partners. We started to engage with the owners and operators of residential care facilities, which are these kind of group home environments within Hamilton. Again, low-income housing, they're subsidized mostly by the city. They're often a first home out of homelessness or a home out of hospital care. We developed the Residential Care Facility Integrated Care Initiative. And what this was wrapping around a comprehensive primary and social care team around vulnerable housing environments that serve low-income individuals. Based on, healthcare data use, what we were hearing from on the ground, partners with lived experience, people with lived experience, we chose 4 homes in the core. And these homes really felt disconnected from the system. They were part of this housing continuum, but they did not have a care environment wrapped around them, even though they actually house some of the most complex individuals in the city, extremely complex mental health and addictions, chronic disease, and poverty. The results of our integrated care initiative for the residential care facility were that primary care started to become delivered to the person's home for the first time. We assigned a primary care integrated care team to wrap their arms around these homes. They started to come on site once a week. Every person that lived there was offered a house physician. But with that house physician came, community connectors, nursing, home care coordinators. Not only did the care come right to where people were housed, but advocacy issues for things like pests and making appointments and the safety of the home really actually became a team effort. So the community connectors came into these homes. They helped to bridge some of the health and social care, help get people off to cancer screening appointments, dental care. We did some cultural safety and training, even just naloxone training for the staff that work at these homes. We heard from people that live there. We feel like we're put on the map. We felt like we were forgotten. We've actually completed some research on understanding the care needs of people who live in these environments, which has actually never been done before. So in terms of next steps for the GIN for this work, it's being used to inform a redesign of the entire residential care facility system in Hamilton. And just this year, we were awarded a $1.2 million grant from the Juravinski Research Institute about improving equitable access to integrated primary care in these facilities. And I know my time is up, but I just wanted to end with a couple of key messages from our experience, and something I actually heard last week that I wanted to share with you from a group in New Zealand, was treating the data as neutral, not as a weapon. People require our help and our support no matter where they are. Let's use this information as a shared collective to do some action. We've really learned just to go. There was way too much time spent in analysis, and I think we all can hear that analysis paralysis is a huge concept. But the further we just analyze, it further erodes the trust with people that are working in the community and those that need our help. So always using our collective muscles together and then adapting. I want to mention that for us, every single partner has a place in this work. I do not believe that our OHTs will be successful if we only focus on health providers. We need those social and community assets, churches, small charities, food banks, not-for-profits, education sector, volunteer organizations. There is tremendous power in equity advocacy as an OHT. We need to be able to organize partners that don't have the time to apply for funding ahead of time. We've been ready for this and received funding because we've actually put in the work with those organizations that just haven't been at the table before. We need to recognize that organizations and communities already do equity work very well. They just haven't been fully recognized in our system. And then we have to listen to communities. This cannot be another checkbox exercise. The acute needs of people who require help and support is just too much right now.